So welcome everyone to the Wilderness EMS Journal Club. Justin wasn't able to be here today, so I will be hosting. We've got a great panel today of a lot of experts in the EMS field. So first wanted to start by going around and asking each of our panelists some questions about their experience, and then we'll probably, depending on time, open it up for some questions after that. So we'll go ahead and start with Ben. Can you discuss your work as a medical director for multiple EMS agencies, disaster medicine, hurricane response, and coastal EMS response?
Yeah, so my name's Ben Abo, like the blood types, and I'm a full-time Florida manologist. I am medical director for 7 fire rescue agencies around Florida, the city of Gainesville, and then all of my others are all coastal, Southwest Florida, and over to Miami Beach, fireboats and search and rescue and all. I'm also the medical director for urban search and rescue, one of the federal teams, Miami-Dade Florida Task Force 1, and as well as tactical. But yeah, mostly the urban search and rescue and the venom response teams. That's it.
So yeah, what can you tell us about your experience working for all of these different agencies at once, how you coordinate all that, what the different experiences are like?
Yeah. So it gets really interesting, especially, and there's a difference being on the federal response team. For urban search and rescue, we are a local asset, and then if we're cleared to go by the chief, we're a state asset, and if Florida's protected, then we will go anywhere. And I've been, with Turkey and the Bahamas and stuff too, for Hurricane Dorian, the earthquake in Haiti, and it gets interesting, as well as being on the federal IST, which is the incident support team that helps kind of coordinate it all from the medical aspect as a medical officer. And there's a bit of a difference with, okay, a hurricane's coming by, and it's usually coming by Florida, and so I make sure all my departments are okay and kind of set up, and then I can go and be with the team. And it was very interesting, especially with Hurricane Ian, where my hometown got annihilated. I lost a number of fire stations and all, and I was there wearing multiple helmets, so to speak. Depending on the situation, the roles and the tasks are a little bit varied in terms of the missions. And sometimes we're out, doing a single search and rescue, single person lost to help out. But with the state of Florida, that's usually dependent on the county with the sheriff specifically, who they'll send out. And then, but my roles overall, first, my team, whether they have 2 legs or 4 legs, and I have a 225 people, 18 dogs. So that's a lot of legs. So it's the healthcare, preventative medicine response first for them, and then coordinating the safety and all for going out. And then if we have anyone that we need to take care of or rescue, such as when I was running things for the Surfside building collapse, or even when we're dealing with tornado spin-offs from a hurricane or the hurricanes, we're coordinating the overall searches for anyone, including their pets and hazards, and going in. So it might be, hey, we think that there's people in this building, we need to search it. So then I'll get there, and then we find people trapped in a house that was kind of stuck, or they're trapped in the attic with the floods going up and dealing with that. And one of the most interesting things out of that was deploying up to South Carolina for Hurricane Florence. And we had someone that refused to evacuate, and they were last weighed at the doctor 782 pounds. And I think that's the only documented bariatric water rescue. They still have to publish. But so that was interesting, because having to do medical command via drone and talk to everyone and figure out how we were going to get them out and evacuate, and continue providing care. So it depends, but I like that we're the Swiss Army knife, so to speak, and the tip of the spear, really having to figure out, it could be any sort of hazard. And I might be blessed to have DMAT. I might be blessed to have a working hospital, or I might not have anything. So just trying to get my guys to think differently.
And how did you get into EMS?
I've been addicted to EMS for about 28, 29 years. So I refused to grow up. So I was raised in South Jersey, and the day after I turned 16 was my first shift volunteering on the ambulance. And I've been doing EMS almost every single day, something since then. And so my bachelor's degree was EMS. I went to college where I was lucky enough to meet Seth. Not to say that he's much older, but he graduated residency when I was graduating undergrad. And
What was that, Ben? I can't hear you. Speak up.
Megan, get you a hearing aid, old man. I love you. So, but I actually went to college expecting to, and I accidentally did the major, but thinking I was going to be an emergency physician, and I was just so addicted to all things EMS, international consulting and stuff. So I stayed as pre-hospital and doing international consulting there in Pittsburgh. And I realized I could do a lot more for the field of EMS and kind of growing and blasting through that glass ceiling as a physician and still as a paramedic. Also, so I continued on, went to med school, and everything since has kind of grown on to that, creating my niche and my sub niche and my sub niche, kind of cutting through. And well, I've always loved nature and the wilderness and respect for wildlife and everything. And kind of that combination of being resourceful in little to no resource environments, with international development, creating EMS systems abroad, disaster zones. That's wilderness medicine, austere medicine, extreme medicine. I will say also that I'm very proud that right now I'm the only fellow of the Academy of Extreme Environment Medicine in the hemisphere. So for now, until these guys get it. But I caught that bug, like I said. And it's been a big mission in terms of getting people to realize that wilderness medicine is not just going camping in a tent, climbing Mount Everest. I'll helicopter to Everest Base Camp, but I'm not climbing Everest. But you might have wilderness EMS and things like that and search and rescue right in cities or around, and deal with drownings and envenomations all the time, even in the urban environment.
Great, thank you. Chris, this one's directed at you. Can you discuss your experience with search and rescue, swiftwater rescue, and specifically you were in the area that was hit pretty hard by Hurricane Helen and how you were involved in any response with that?
Yeah, so I'm Chris Davis. I'm also an emergency physician, EMS physician, and wilderness medicine bro, I guess you could say, in North Carolina. So I've worked with a lot of these people a long time. I was also kind of to tie into this whole journal club. A number of us on this call were just published a paper that I think some of you probably read, sent out beforehand, on this medical direction of search and rescue teams. So my kind of niche area in EMS and wilderness medicine is specifically in like the provision of technical rescue. My background, so I got into EMS while in undergrad. Started out as an EMT, really from the guiding background. So I was a guide, in both a whitewater guide, a climbing guide, and then I did sailing trips sort of seasonally. And after college, I worked guiding full time, and went and got my paramedic like at night, and worked part-time as a paramedic. And then was just kind of looking for more and more ways to blend these things together. I got involved with technical rescue and mountain rescue and some USAR things at the time, and ultimately getting involved with that, doing that internationally and stuff. Medical school made a lot of sense to try to expand my horizons and my skill set and stuff as well. I've stayed very involved with both EMS and technical rescue. From that standpoint, I'm on a mountain rescue team in North Carolina, along with Seth. I think I don't think anyone else here is on that particular team, but we support the state parks in North Carolina with with Mountain Rescue, and also I've been working with the National Park Service for a number of years, teaching technical rescue to the both in rope rescue and swiftwater rescue, and helped develop the Park Service's swiftwater rescue training course that they're doing now. It's gonna be in its 4th year this year. So a lot of that, I try to bring the medical perspective into these worlds that are typically, you know, many people have medical experience and stuff in there, but are really focused on this technical hard skills of doing the rescue. And something that I think many of us kind of will speak to, I think, is this idea of medically directed rescue. And that's a kind of one of my big things, is trying to bring good medicine into the provision of medical care, kind of thinking that both rescue as medicine and medicine being part of rescue, right? So you kind of can't get them apart of things. Sometimes someone just in a bad place and they're fine, but more often than that, people end up in a bad situation and they're hurt or sick. And you don't want to, you know, have a singular mission. I think in the best rescue is incorporating both things together, that you know, your medical priorities inform your tactics, and vice versa. And so it's really great to have people that have have expertise in both areas, or at least know how to speak each other's language so they can communicate and like prioritize patient care. I've also was involved with, along with some of the other people on here as well, in some response to Hurricane Helene. I think Seth maybe can speak to this very well based on some of the stuff I just read that he put out just the other day. But we were all very much involved with, you know, in all of us in Western North Carolina in the response to Hurricane Helene in many different ways, some that didn't even seem to be, you know, directly like what you'd think of as a disaster response. Like the first 2 nights, I was working overnight in our tertiary referral center for Western North Carolina, the kind of the furthest one that was out that was not impacted by the storm. And it really took out the infrastructure. You know, it took the only trauma center west of us offline, and stuff. So I basically all night was coordinating and receiving transfers. And that went on for for a week of trying to get everyone out of there. So by even just working a regular ED shift, when we were really in some ways practicing disaster medicine, right there on a normal shift in a regular ED that was unaffected by the storm, you know, that is all part of the response. I also went out and did some searching with our rescue team, searching along river corridors and things, and then spent a week in one of our temporary care centers that we set up through the Office of EMS that provided basic medical care services. And you think a lot about disaster response and things, and many of my colleagues here have done significantly more than I have, but you really start thinking about like, oh man, we've got crush injuries and people trapped and all this stuff, but then you start that really gets you through just a couple of days of it, but we're really still dealing with it now, and very quickly you start to realize that the things that people need are that their doctor's office isn't open, their pharmacy doesn't have power, and they can't get their blood pressure medicine, or they need, they just have a cut or something, there's no urgent care. So that a lot of what we were doing is simply just replacing and supplementing the medical infrastructure that was not there for just routine regular medicine, which you come into a lot of this thing thinking I'm going to be a hero and rescue people out of like certain death, but a lot of disaster response and things is like refilling someone's hydrochlorothiazide, or like helping someone find somewhere to get their dialysis, or things like that are much less sexy. So, but really, I think the cool thing about all of that really falls under this umbrella of wilderness EMS things is this provision of pre-planned, organized medical care in the wilderness. That is not ad hoc, it's not improvisational things, that we actually plan for, train for doing these things, and we're ready to do it. So I think I will cede the rest of my time to the next person.
Thank you. David, if you don't mind introducing yourself and then telling us a little bit about the work you've done in Red River Gorge and what exactly a wilderness paramedic is and what you've done to kind of help advance the scope of those practitioners.
Yeah, sure thing. So my name is David Pfeiffer. I am the least intelligent, but I think, frankly, most physically attractive member of this panel. And I'm a paramedic, and had sort of a similar journey to Ben, actually. I became an EMT when I was 16 in Virginia, and caught the EMS bug and have stuck with it ever since. And so I'm going into my 25th year in EMS, and really, really love being a paramedic. And I guess I've sort of developed a specialty of wilderness EMS. And one of the concepts that's already sort of been highlighted a little bit so far is the distinction between wilderness medicine, which involves themes like improvisation, and sort of ad hoc patient care, from wilderness EMS, which really definitionally is the organized delivery of regulated healthcare in the wilderness environment under medical direction and regulated by authorities and all that kind of stuff. So that's kind of what I've done. And I also do a little bit of disaster response myself. I'm actually on a NDMS, National Disaster Medical System deployment right now. Happens to be for a national security event, the Carter funeral, but I respond to hurricanes and similar kinds of disasters on that side of the coin as well. My I guess involvement with wilderness EMS has been that Kentucky, like many states, so I reside in Kentucky. I guess that's important context. So Kentucky, like many states, especially kind of east of the Mississippi, probably east of the Rockies. Generally has like volunteer search and rescue teams that are not EMS agencies, they're not healthcare agencies. And they may have woofers and other sort of wilderness first aid kinds of personnel on them. Sometimes they have people on their rosters who are uh, healthcare providers. They hold credentials in nursing and paramedicine and physicians and all kinds of different roles, but the search and rescue teams are not EMS agencies. And again, that's very, very common in this part of the country. And so when I started getting involved in search and rescue here in Kentucky, I was really frustrated by that. I was working as a firefighter paramedic and responding predominantly to an area here in Kentucky called the Red River Gorge. And if you're into rock climbing in particular, you probably know about the gorge. It's really a world-class rock climbing venue. We have a lot of cliffs and a pretty extensive trail network, and we get a lot of search and rescue calls every year. And I was on the search and rescue team in the area as a essentially a lay member. I had my paramedic credentials that I kind of carry with me all the time, but in the search and rescue mode, I really couldn't access that skill set. I could bring that knowledge with me, but I couldn't really legally operate as a paramedic. So the ambulance would stage at the trailhead, and that was pretty typical. And then the search and rescue volunteers, we would go in and find these patients with, like all manner of illnesses and injuries, and could really only render first aid. So I set about trying to close that kind of gap in care and build a wilderness EMS agency. So kind of long story short, I founded an agency called Red Star. Stands for Red River Gorge Special Treatment Access and Rescue Team. We completely ripped the name off of BORSTAR, the Border Patrol Special Trauma Access and Rescue Team. But Red Star is a full scope wilderness EMS agency, predominantly ALS. We have a couple of EMTs on the roster, but we're all paramedics, advanced practice nurses, and physicians otherwise. So I've been building that program for about a decade now. And then that has also morphed into becoming the ALS air crew for our Kentucky State Police Hoist Rescue Team. So Red Star ALS providers provide the hoist rescue paramedics and nurses to that helicopter. And then I think kind of as an outgrowth of some of those activities, or those activities kind of led me, to meeting people like the rest of these panelists, and that eventually led to the development of the WPC credential. So there's an entity called the International Board of Specialty Certifications that kind of promulgates specialty certifications for paramedics. They're most famous for their flight paramedic certification, which is basically the standard for paramedics in the air medical community. They have a few other certifications as well for different specialties like tactical medicine and community paramedicine and so forth. But at this point, I guess probably 3 or 4 years ago, here in Kentucky, we were interested in really creating wilderness paramedicine as a true specialty with an expanded scope and all of the sort of like regulatory, basis that you would need to really do true wilderness EMS and not just like wilderness medicine as a paramedic. So we were searching for, like a third-party exam or certification or something like that to basically sort of like credential, these new Kentucky wilderness paramedics. And so we turned to the IBSC, and they were interested, and there was traction behind this. That led to the development of this, the first really sort of international third-party objective cognitive exam for wilderness paramedics, at that really kind of like high level of knowledge. And then to kind of wrap up my little spiel, I guess. So at this point in Kentucky, we have a additional scope of practice beyond, just sort of like regular paramedic called advanced practice paramedic. It's its own licensure level, and there's special qualifications for it. And you can specialize in one of the IBSC specialties. So you can be an advanced practice paramedic who is a flight medicine specialist. You can be an advanced practice paramedic who's a tactical paramedicine specialist. And so if you want to be an advanced practice paramedic who's a wilderness specialist, you have to, among other things, possess that WPC credential. And we have a really significant scope of practice that is really a reflection of like the best practices kind of recommended by the Wilderness Medical Society in different white papers that have been written and different clinical practice guidelines that they've written, and NAEMSP and a lot of their positions on specialty paramedicine practice. And so we built this evidence-based scope of practice that reflects all those really like expert consensus guidelines for what you really ought to be able to do for your patients out in the wilderness. And that level of licensure is just about 2 years old. And to our knowledge, we're the only state in the nation that that truly has a kind of like a standalone wilderness paramedicine licensure level with a scope of practice unique and specific to that. And the beauty of it is it's all regulated by the Board of EMS. There's no hot dogging or freelancing. It's all under medical direction, and it's pretty cool. So that's me.
Thank you for that. We'll jump to Seth next. Can you introduce yourself, discuss your role as the medical director for the Virginia State Parks and your work with Wildland Fire?
Yeah, I'm Seth. Glad to see everybody here. And like many of you, I have similar roles in these kind of spaces, so I can describe them and maybe talk a little bit about how they might land for people as learning lessons. So I do work with North Carolina State Parks as the medical director, and also U.S. Forest Service for all the U.S. Forest Service properties in North Carolina. That does involve a good deal of wildland firefighting, medical direction for both entities, also including the Asheville hotshots, which are slightly different from the traditional U.S. Forest teams. I also work with the National Park Service in the Outer Banks as a LEMA, and like many people on the call, I work with the Mountain Rescue team, a Mountain Rescue Association team in the Southeast, the Appalachian Mountain Rescue team from a field response and sort of board level. Organizationally, I work with NASAR as the medical director, and also work with the Wilderness EMS medical director course, which Ben and Will are on, along with Michael Millen, who's not on the meeting here. And that serves to train physicians and potential medical directors in the medical direction and oversight of wilderness teams, and edit a book on wilderness EMS. So more germane to the wildland fire topic, which is very timely right now, and where I know we're all thinking about California, and that is a bit the story, and it's what all the modeling and prediction suggests from a climate change perspective. I went back to school for graduate school to get a degree in public health and anthropology, and my master's thesis, which hopefully wraps up in May, is on wildland fire and the health and cultural parameters of it. So I do think one of the messages I have here is the public health nature of what we do, and the fact that oftentimes in EMS we're talking about populations of people and how to manage them and or care for them. And also I would just make a pitch for the anthropology element of this, that we're dealing with human beings, and there's a rich social science literature out there on how to take care of people and communities from a culturally sensitive and humility perspective. So I'm also the medical or assistant medical director for the Eastern Band of Cherokee Indians, who abut the Great Smoky Mountains National Park, are involved with some of the wildland fire work there, but also a lot of the search and rescues in that community. And notably, Clingman's Dome, just a couple of months ago, was renamed back to the Cherokee original name of that geological structure. So that's sort of speaking to the ways that we can be players in some of the cultural and public health milieu of the spaces that we're working in. So just throwing out a bunch of things there in case they land for anybody and anybody wants to talk further about them.
All right. And Will, can you go ahead and introduce yourself, discuss your role as the medical director of Grand Teton National Park and the Teton County Search and Rescue?
Yeah, so great to see everybody here today, and exciting things to be talking about. I think most of us have probably about 20 or more different hats. So I'm an ER and EMS physician in Jackson, Wyoming, and do co-medical direction with one of my partners, Dr. AJ Wheeler, for pretty much all of our response agencies in Jackson, Wyoming, and the Tetons. So that's Jackson Hole Fire EMS, Grand Teton National Park, Teton County Search and Rescue, and then Bridger Teton National Forest. And I've also got an Army Reserve hat, work with ICAR, chair of the drone working group, and so multiple other things that we all have to kind of just cross-pollinate across all these different silos. But yeah, doing medical direction for Teton County Search and Rescue, both Dr. Wheeler or AJ, myself, I mean, we're full-on response physicians. We do short haul, we do cave, avalanche, swift water, pretty much all the technical rescues. And so doing patient care, wilderness medicine in those settings. Again, I think like Seth just mentioned, his textbook on wilderness EMS, which probably most of the people on the panel have all written or contributed chapters to, is probably the best textbook out there for really this organized response in the wilderness EMS space. So you can do wilderness medicine and you can improvise kind of SAM splints into doing different things, or you can tie rope litters and do things, but kind of really thinking on how you do an organized EMS response, whether or not it's a search and rescue patch or ski patrol patch or kind of whatever response capabilities, where you actually have a little bit of forethought, figuring out what medical things you're going to take from your traditional EMS response. How are you going to shrink that to the Cuban weight that you can put in your backpack with all of your other personal safety gear, your technical rescue gear? And so kind of what can you put in that little ball that you're going to be able to take care of patient care? What's the most important? Talking about kind of some of those operationally specific protocols and things out there. And so it's fun. It challenges you every time you go out. Every call is a little bit different. And so, yeah, I've got a passion for it since I was a EMT in high school. So I got my paramedic before medical school, and now just kind of get to go out in the field and kind of do fun stuff every day almost.
Great, thank you. And then Michelle Curry is multitasking right now, so we'll come back to her in a little bit for some questions directed to her. In the meantime, for each of you, I want you to tell me about one of your most memorable rescues you were involved in.
Here, hold on, let's go now.
Oh, we have the Cassie.
yeah.
Yeah, we've got another guest
Bonus?
edition, bonus guest.
Bonus. I'm a bonus. I'm Cassie Lowry. I'm the current chair of the SAR committee for the WMS. I got my start about 12 years ago before med school, so I have a really good habit of doing things non-linearly. So I got my start in EMS. I'm now an urgent care physician in sunny San Diego, where we are. And I mostly ended up focusing on the systematic problems that I was seeing, where there was this big divide between EMS and SAR. I was part of a very large organization in Washington State, in Snohomish County. We had at the time about 350 rescuers, and our EMS medical director, since we were through the county, did not have any SAR experience. So we didn't have any direct medical leadership that kept us consistent with any of the EMS protocols. and really kind of a smattering of different trainings for different levels. And so I was seeing a lot of gaps in the field, and then a lot of concerns, in particular coming from even our SAR deputy having nightmares from knowing whether or not he made the right call, because there weren't really protocols designed for that out in the wilderness. We did a lot of drownings. There's a lot of waterways in Washington state, as well as hypothermia, which is year round. So there's a lot of combination of those things, including a lot of kid recoveries and rescues. And I was seeing a huge impact on the human side, where I could start to fill in that gap on the system side and the protocol side. So I really started driving that, well before I started med school. And then a lot of my career through med school, I continued search and rescue through medical school, and then residency, I've just been bouncing all over the place because that's what I do. And so I've been continuing to, push that, help provide clarity. That was, that CPG was very, I think, personal for me with my experience in rescue, and encouraging other, medical trainees to step up as leadership in their communities. So I did get involved a lot in education in the Northwest region, and founded a nonprofit that runs a student conference every year. And fortunately they survived COVID, so they're still doing that thing. So that mission I set off with is still in play, which warms my heart. They just had their conference last week. So I've been really fortunate to be able to kind of step back, finish residency, and start to get my feet underneath me, and keep doing, the work that meant a lot to me just to begin with. So that's it. That's me.
Thank you. So most memorable or educational rescue you were involved in, if you want to just volunteer to talk, or we can go back in the order we were in before. Start with Ben, whichever you want to do.
Table me, come back to me.
Okay.
I want to think on that.
Chris?
Yeah, I'd say probably one of the most, relevant to this conversation was actually a number of years ago, a few years ago in Linville Gorge. We had a rock climber who kind of made all the classic errors, was a gym climber who wanted to go, do their first big outdoor climb, but decided to pick one of the most remote routes that was really far from the trailhead with a group of other inexperienced partners. He didn't make it very far off the ground. He made it about 15 feet and fell, and his first piece of gear pulled, and he ended up with an open ankle fracture. And they started this, classically in October. They left the trailhead around 1 p.m. to start this route with like a 2-hour approach. So it was like getting dark by the time they made the call. So I got out there, and then I was on the radio on the way up there, and as the response was beginning, I was hearing that basically no one was making it all the way to the patient. Like somebody's started to get out of breath, someone hurt their back, someone else from the local rescue community. And by the point I got in the parking lot, only 2 people had made it to the patient. And I was coming from over an hour away. So that was but we basically as I was coming in, I was kind of thinking about how we're getting this guy out of here. It was areas I was familiar with, but we had 3 rescuers that could make it to this patient at this point. And we do have a hoist program available in North Carolina, but it's very constrained by time. It takes a long time to spin them up. There's nobody sitting there ready to go. They have to call people in and pre-flight and all sorts of stuff. They had already activated it, but as I was going in there, I was noticing the winds were getting pretty high. It was very, very windy. We were able to assess the guy when I a couple of short rappels, able to get down to him and stuff. But the person that came with me couldn't make it because they got out of breath. So I ended up having to go by myself down the rest of the way in there and meet the other people that had made it down there. And so it's just kind of all of a sudden you're there with 2 guys that I've worked with a lot that were there. And we had heard, and we were calling the radio that there was probably a Black Hawk coming. So we were great, because probably. So, but in the meantime, I worked on some pain control. The guy had a bad open fracture. We cleaned it out. I did some some local anesthesia and stuff to it to try to help with pain control. Did a nerve block. stuff, and was thinking about whether I was going to try to reduce this in the field or not. And the thought was basically like, if we can just get him out of here, let's just get him out of here. If not, we're going to probably be here all night, because we would have had to do about 3 pitches of steep slope, raising, and then go through a steep gully with only 3 of us to do it. So that would have been pretty difficult. But ultimately, we were able to. The Black Hawk was getting on scene right as the sun was starting to go down, and it took them about 4 tries to drop the cable down to us. It kept getting blown into the trees and stuff that we couldn't get it. We were able to ultimately hoist him out after a bunch of different attempts and stuff. But they had sent one of their rescue specialists down, to one of their hoist operators, 2 of them. They possibly had to have one on the ground too, but they were unable to retrieve him. So then all of a sudden, now it's dark. The guy didn't come down with any survival gear, was in like flight boots and a flight suit and no warm gear, and it's now dark and no headlight or anything. So we basically, after getting this guy out, we were like, heck yeah, and we were gonna, often they'll hoist us out too, and then we get to go back. But it's just, I think one of the memorable things was being, even if everything goes right, you still may be prepared to do a lot of extra stuff. So we ultimately then had to not only hike back out in the dark and but I actually had to guide a person out that was not equipped to be out there at all, back out. That was one of the other rescuers. So it was some of the big takeaways for me is that, like, think about stuff that you it's kind of a no-brainer in some cases, but if you want to get involved with the rescue, like, prioritizing your own physical fitness is actually like really important. Like, you should make sure that you're gonna be able to complete the mission, depending on what you're doing. So that's a really important. It kind of reminds me every time I think about that, I'm like, I don't know if I'm gonna go to the gym today. I'm like, yeah, I probably should. So that was a big one for me. And then also just always having at least the contingency resources to be able to spend the nights wherever you go, even if it seems like it'd be quick or simple, just be ready to spend the night. So well said. Yeah.
Awesome case story. I'm going to go ahead and interject some of these questions between these cases that we're discussing as they come through. So first one's from Jeff Comp, and this is probably for all of you, since we're probably going to get some different answers and different experiences on this. For those of you with EM training, how much do you practice clinically? How do you balance and navigate the need for rapid deployment? Say you have a shift the next morning, but you're getting deployed or getting called.
I'll start off on that.
That's probably at the lowest end.
Yeah, so I have a goose egg. I don't work clinically in the ER. I haven't for 2 years. My clinical practice is all my disaster and EMS. Although I'm about to start doing 2 shifts a month, just because I do kind of miss it, in a critical access place in Louisiana. However, when I started off in the academic, I'll keep it as short for as long as I can. When I started off academic after I did EMS fellowship, and then I stayed there as faculty, as assistant professor at UF, for 3 years, and then went to a non-academic community hospital. In both places, I told them, like, even before I started, hey, like, this is what I do. My primary thing is this. You're gonna have to let me go if something's creeping up. And luckily, usually, with the exception of Haiti and the Surfside collapse, hurricanes you usually know are coming up. Like, hey, this time of year, I'm probably not going to schedule stuff. I try to spread my shifts out. Hey, Will, I've got this hurricane might be something. If I have to, can you cover these shifts? And so I try to plan that as much ahead of time. At the latest, it's usually like, this is going to hit. We're the Navy SEALs of the USAR. They're going to send us. The governor called us that. I'm not just saying that. And so try to plan ahead, but it was always hard. It was always difficult. So you had to make sure it's really understood by everyone. And I will say that I proactively, no matter what, it's like, oh, Chris and Cassie are covering some of my shifts, even though I'm going to make the shifts up to them at whatever shifts they want me to cover for them, I will. I still get them while I'm deployed, like a massage therapy or a gift basket or fruit basket, something as a, hey, because you helped me out, I was able to help these others. Thank you. And it was just a personal thanks. So that helped win most of my colleagues over. but it can be really hard. Like Surfside building collapsed at 1:14 in the morning, and had no idea that I was going to spend almost 30 days there. So suddenly you have to have everyone else kind of cover shifts and stuff.
Anyone else have any different experiences or input on that?
Yeah, I can chat. So in my small group that we've had 5 or 6 partners, and so it's definitely a big kind of impact. So with my military deployments for going 2 or 3 months or 4 months overseas, a little bit more planning for that to be kind of out of pocket. But usually for our group, if you're on shift, you just aren't able to respond. And so I think that's also the thing as being a medical director for the system, is you should make sure that the system functions without you, and so that you can train kind of all your responders in the field to not be reliant on you. So I think being in kind of EMS doc, paramedic before I went to med school, and still a paramedic, keep that up. It's more fun to be out there in the field doing all these things, but somebody's got to work those ER shifts as well. So I think you just have to find the balance of kind of what your group will tolerate and allow. And bigger groups sometimes have more redundancy, but I think it just depends on something that you need to think about.
Yeah. So for me, I'm in a large academic group, which helps with some of that. I work about 50% clinically, maybe a little bit less. And so a lot of my other responsibilities are more flexible. Like if I'm teaching a course or I'm teaching the med students or something, that's fairly easy to just reschedule at the last minute if I need to. I've got protected time for EMS medical direction and stuff as well, which helps with that. And then I have a lot of academic time, things where I can do research at other times as if I need to. So that helps. And then it also, I think it helps for me. We have a very large academic faculty at my group, many of whom also, I think the average is most people are working 50% or less. So that offers me a lot of flexibility for other people to be able to pick up and we help each other out for we have a lot of hurricane deployments, stuff like that. Some people go out to and things. So that helps to be in a bigger group that has a lot of other people that do a lot of things, so that it's not like I've been at some places where everyone only just does this, like they just work their shifts, and it was little bit harder than when you had a lot of people that did a lot of other things. So it's like, well, this time I need to do things, but next time it's gonna be someone else, and like it's everyone just kind of picks up for each other. So
Yeah, I would plus one everything that everyone's saying, and it's so much about relationships, and ensuring, the circumstances of jobs will be different, but not making assumptions that people will either be able to cover for you in your home shop professionally, or that your home relationships will be able to sustain it. And I think that's often not shared enough, that we need to be protective of our, of the relationships of people who love us and are also left in the lurch if there's not good communication, if we launch rapidly. Just one interesting thing I would say to what Will brought up is that we do have this perception that we like being in the field, but somebody has to work in the ED, which is a story. Like, that's an assumption that we make. And so as Ben pointed out, I guess I'm the old guy on this call, and I came up out of Pittsburgh in an era where Abby Wolfson told me I better find a real job instead of hanging off cliffs, because nobody got paid to hang off cliffs and be in the field. So hello from the 20th century. I can say my mentors said you couldn't do this except recreationally. You shouldn't expect to be paid for it. I think we've gotten to a middle ground where now there's like, it's a 50% ground, like Chris said, where like maybe 50% of your time you spend in the ED, but there's no reason why there can't be a world, if people love to work in the field, that we can't be compensated for it. So Jeff, I know this is like not so helpful for you because you're talking about tomorrow, and I'm talking about like aspirationally in 20 years. But as we think about this as an industry, there is an interesting paradox that EMS suffers from paramedics and EMTs getting pulled out of field medicine to get allured into nursing or medical school or things that are apparently better. And then the world is full of nurses and physicians who wish they could get back in the field. So as we advocate for this as an industry, I think it's important to recognize that if people have a propensity to be in the field, I know this is probably true for many of you, 3/4 or more of my partners have no clue why I would want to go out tomorrow night when we're getting a snowstorm in North Carolina and pull people out of like snowdrift. So it's not the case that everybody wants to be out in the field. Some of us love it, and there should be a job track for that. But bottom line, relationships, building, understanding, not taking things for granted. The other big thing I would say is accept disappointment. I've got 4 of my best friends in the world sitting in a conference room in San Diego, and I'm not there. Really, really bummed. But what that means, Jeff, I think you already know this, and everybody on this call probably knows it, is that a lot of having a medical career involves triaging activities and getting used to disappointment. And if you do try to do it all, you get crushed. So just accepting that, like, there's, that was my message in the chat about, Chris Davis having this awesome call in my county. Like, there will be things you don't do, and that's okay. And you have to be comfortable with that.
Got another question coming in from Alex. What advice would you give for EMS providers who work in urban settings who are looking to branch into wilderness or austere medicine? And Seth has already put some good comments in the chat, so I encourage everyone to read that. Does anyone have any thoughts or feelings on that?
Well, I can take a crack at it because I actually sort of made that transition myself. When I really took a deep dive into wilderness medicine, I was working in Washington, D.C. as a paramedic. And so that little story, just by the way, is I was running the campus ambulance service of George Washington University called Emerge. And the outdoor trails or outdoor recreation student group asked us to deliver a wilderness first aid class to them. And I wasn't totally unfamiliar with the whole field of wilderness EMS. I had been a search rescue volunteer as a teenager, and just sort of like generally knew about wilderness medicine, but very generally, and I wasn't really into it at all. But they, asked us to deliver this course, and I was like, well, I go hiking and backpacking and all kinds of stuff. And I certainly know how to teach first aid. So let's find some sort of curriculum, and kind of how hard could this be? And then when I started reviewing the curriculum that we had chosen to deliver to them, I was like, man, some of the stuff is a little bit odd. I remember one of the teaching points in that was a graphic to you could hold somebody's airway open by putting a safety pin through their tongue and running some string through the safety pin, and then like tying it to a button on their shirt. No offense to the person who came up with that graphic, but I now use that in my lectures about things to absolutely not do in airway management. But that was kind of like I was like consuming with this stuff about like austere, first aid and wilderness first aid, and I was like, man, this is pretty goofy, and like there's got to be some better ways to do some of these things. And so that long story short, that's kind of what eventually led me to like the Wilderness Medical Society and some other organizations like that opened up this whole world to me. And then I decided, partially that's what helped me decide to move to a place where there was more opportunities to do that. So there's a little bit more to that story as well. I had some other motivations for wanting to move from DC, but that was a definitely trigger for kind of making that decision. And so one of the things that the reason I kind of bring all that up is that one of the things that I found when I was exploring all this, and I wanted to, I was an urban EMS provider. Now I was kind of like making a pretty conscious decision to kind of go in this other direction. I started looking around, and in many of the places of the country that seemed to be like initially attractive to me, where there seemed to be a lot of wilderness medicine and wilderness EMS occurring, it seemed like really difficult for me to figure out how to get off the career track that I was on and have another kind of lifestyle and another kind of career. That was very scary. So what I'm talking about here is like, becoming like a ski patroller, and then what was I going to do in the off season, or becoming a park ranger. And at that time, the expectation was that if you wanted to be a national park ranger, you would work several seasons as a seasonal ranger and then compete for a permanent job. And that was also very scary to me for kind of the same reasons of like instability and like what was I going to do for like health insurance, when my season ended and things like that. A lot of that has changed now. That whole kind of like labor market has changed a little bit, but I still think some of those challenges are still there. Many of the places where these career tracks exist are also difficult places to live. They can be very expensive. I'm sure, Dr. Smith could talk about how expensive it is to live in, Jackson Hole. A lot of times the departments out there are pretty competitive because a lot of people, paramedics and firefighters and so forth do want to work out there. Even some of the volunteer sort of like search and rescue EMS teams in a lot of these like hot spots of wilderness EMS are themselves super competitive. And they're not even going to let you on the team unless you've, summited some big mountains or, stuff like that. And so I started to set my sights on places where it seemed like there was wilderness EMS work to be done, but where it maybe wasn't these like meccas of places to go, where it was going to be so competitive. So basically, what that meant for me is just I had gone to college here in Kentucky. I went to EKU as an undergrad. And so I knew about the Red River Gorge and I knew about the high volume of calls there. And so I basically started applying for agencies and paramedic positions, in the area of the gorge. But a big part of that was I knew that I could join a search and rescue team that was involved in responses, to that venue. I knew that I could do it. I knew that there was like a pretty high degree of certainty that I could like find a job and I could get involved in wilderness, medical response. So I kind of like intentionally like didn't even try to compete for getting on with like, YOSAR, climbing rangers or, Teton SAR or any of these other places. And I think that actually, if you look around a little bit, you'll find that those kinds of opportunities exist in lots of places. There's areas, kind of all over the country where there's a lot of wilderness and a lot of search and rescue responses. And if you do a little bit of Googling and Facebook page following and so forth, you can probably find those pathways that might not be so scary and so arduous, and it might be a little bit of a safer bet to transition, from that urban environment to the more wilderness kind of environment. And then, once you do that, and once you do get involved in that, then you start networking with people like the people who are on these panels, and then you start to see how to craft really a more long-term kind of a trajectory for yourself in this. So that's my perspective, is like, maybe don't try to go NFL right at the beginning, and look at some other parts of the country.
Thank you for that.
David said it really well, and I think that, I don't think there's any one of us that are on the panel where it's like, oh, I just applied for this, we just did this track. Like, that kind of doesn't exist in a lot of places, and there's all different forms of forging your own way or getting on with a team that exists. That, like, you might not have the opportunity to, think that far ahead and be as smart as, Professor Pfeiffer, but think ahead and kind of do that, or you might not be able to move. Like, you might be, I remember some of my classmates in med school that didn't even choose their specialty based on what they wanted to do. They applied to multiple specialties because they had to stay in the Bay Area, or something like that. So there are different things that are out. So it just kind of really depends. And I think the most important thing is to have an open mind to network. Success is measured by the size of your Rolodex. That's something that Seth would understand, what a Rolodex is. But it's all based on connections and mentorship and being a mentor, being a mentee, coming up with different ideas. Like, I mean, look at Red River Gorge. That team didn't exist. He saw a need and he created it.
Yeah, I would say is like an aspirational level team, it's like
Yeah.
one of the better teams out there for sure.
And it's amazing, and like, I have people all the time, they're like, oh man, I want to do urban search and rescue. And it's like, cool, this is what it actually means. So you have to kind of dig, and if you're trying to do stuff and do different things, finding what you want, I don't think is necessarily easier possible, and I definitely don't think it's as important as figuring out what you don't want. because you might end up inadvertently creating something that's even better than what you couldn't have even imagined of what you want. But a lot of it comes down to open mind, humility, and as Seth said, relationships.
Thank you guys for those very thorough answers. Michelle is joining us now. If you don't mind, go ahead and introduce yourself, what you do, what your background is, and then maybe discuss your role with the Forest Service Medical Director and how Wildland Fire and EMS are involved in that.
Great, thanks so much. Can you hear me okay? Do a sound check first, yeah. So my apologies, as you'll hear in my introduction, I am indeed multitasking this evening. So Michelle Curry, and my background is of course emergency medicine like most folks. I'm probably older than Seth, so I think I'm gonna have to be maybe the oldest one on the panel. I'm feeling pretty confident in that. But anyway, and how did I get to, I think what I've heard in the background as I've been listening is a lot of like, what do you do in the wilderness world and how did you get involved and kind of what is your role now? So my current role is I'm the National Medical Director for the U.S. Forest Service. And that is a new role that just came about. This will actually, February will mark year 3. There wasn't one before that. And we had EMTs across the country that figured out how to do things in a variety of different ways. And as the rules in EMS have changed in the 25 plus years that I've been involved with EMS, the agency did not change along with it. And so we were kind of out of compliance. Eventually the Forest Service came on board, and that's how I got a job where I'm at now. My other past experiences, again, like all these great people on this panel, we've all sort of come up through a variety of pathways and had a variety of experiences. So I did start out active duty military. I am still on a National Disaster Medical Systems team, so a DMAT team. And as Dave Pfeiffer is in on a current assignment, my other meeting I was listening to while I was watching you guys was my briefing for an upcoming assignment that I will be headed out on with my DMAT team. So there you go, kind of multitasking. I think the other discussion, I was trying to listen to both conversations, was, clinical time. So I do still work a little bit clinically. The Forest Service job is a full-time position, and it comes as an employee of the federal government with government benefits, et cetera. But the problem is there's no, the Forest Service doesn't have a hospital. I know, shocking. So to keep my licenses active and my clinical skills current, I do still work a few clinical shifts. Once I took this job and completed the transition and decided I was going to keep it, I was able to find some part-time work where I just do a few clinical shifts a month. In all of my years with NDMS, which is quite a few before I started this job, I would get called on deployments a lot. And I know that was a lot of the questions. And the notice is sometimes very short, and you can be out the door and maybe you have a shift. I saw that question come up. For me, I've been blessed. Every place I've worked, I've been very upfront with them. I'm on a team. I do know what months I'm on call. I can give you that heads up, and I'll give you as much notice as I get. And I've always worked with a set of colleagues who knew that going in and were very gracious and would cover my shifts to the point where I just had to pull in some favors even on my part-time job to cover me for this mission that was not on my radar. And so even in part-time work where I don't know the people well, people generally will step up, and sometimes you do have to do a little bit of payback, but it's important to just be open and honest ahead of time. As far as wilderness medicine in general, how did I get into it? I guess it's just a byproduct of military training. My dad was a forester, so I spent a lot of time in my childhood doing all this outside stuff that everybody who's listening to this does, right? Camping, hiking, fishing, boating, kayaking, canoeing. I never got crazy enough to do like high mountain climbing. Sorry guys, those of you who scale those mountains in the Grand Tetons, that's just not my thing. So I was never into that technical piece, and I will still say technical rescue is not something I am an expert in or do a lot of, but that's okay. You kind of find your comfort zone in your niche, and I think For me, what has helped quite a bit is the network. And that's what you guys are building right here. And these folks on this panel, they're all in my network, plus about 150 other people that over the course of my career, I'm like, ooh, this is a cool person. They know a lot about X. And I kind of file them away. And when a question comes up down the road about X, like for Ben, I think I plagued him a few months ago when I had a really weird snake envenomation. I just reached out and texted him. You kind of build that network and you build those connections. And so what works for me in my role as a national medical director, I know very little about most things, but I know a lot of people who know a lot. And so I know who to task. If it's a tactical EMS question, I call Will. If it's a Venom question, I call Ben. If it's technical rescue, I call Chris. Heck, I needed a hotel recommendation in Red River Gorge. I called David Pfeiffer. So it's all about the networking and the communication, and that communication skill, especially in the wilderness environment, is, I think, even more important when you're talking about patient care and transitioning patient care from the wilderness environment to regular EMS to a hospital. There's a lot of different bits where things can break down. So you become a very good communicator, I think, in the wilderness environment. And that's what helps you build the networks, and that's what helps you get where you are. So that was kind of, I was trying to listen to what you were asking the others and broad sweep it all out there, but I'm happy to take any other specific questions.
Well, thank you for being part of this panel. Our next question that came in is for Dr. Smith or anyone else who's been in the Army Reserves. Are there established pathways or roles in the reserves that directly involve wilderness medicine, wilderness EMS, or is that a niche that requires carving out on an individual basis?
Yeah, so I think with a lot of these stories, everybody's got a little different one. For me, the Army Reserve, it's a little bit of a choose your own adventure, and there really is not a clear linear path to wilderness medicine. Yeah, you can get involuntary deployments sometimes to sandy, dusty, hot, other type of places that kind of pop up over the years, but to really do it full time, my military hat's definitely given me a unique perspective on a lot of those things, but I would say you still need to navigate through, and just like Michelle just got done saying, it's about networking, and it's figuring out kind of if there's a position that opens up doing this. And so I think it's really kind of building your career, building your resume, and then that kind of gets you to navigate in. And like David was talking about before, kind of finding a place where you can go and make a difference and establish yourself and find your kind of passion of what kind of wilderness medicine do you want to practice, because there's so many different areas, and it's becoming an expert in that area. And so like Michelle was saying, you got a go-to person in their kind of network for snake bites. I gave Ben a call because I was doing a talk about Africa. And so again, just making sure that I'm up to date on it. Yeah, I could go maybe read a textbook or two, but that'd take kind of more time than I've got. So I got friends just like Michelle. It's like, okay, I've got a pointed question, and then I just go to those. So the Army's been great, but you can certainly have frustrations. And so it's just like a lot of these things, it's navigating through shifts, it's navigating through kind of military hats. So, but it's all fun at the end of the day.
All right, I encourage everyone to keep putting your questions in the chat, and we'll keep getting to them between all these awesome insights. So in the meantime, while we're waiting for more questions, we'll go back to interesting or memorable rescue cases you're involved in. So Chris already went, so everyone else, you're up.
Yeah, so, well, Will's got
Some
some like, okay, but other than the bariatric water rescue, they said, which remind me, I gotta write that up. So, during Hurricane Harvey, again, you're trying to figure out communications like that and different stuff. So Hurricane Harvey was in Texas, and so we went out there. We found out that there was a woman who hadn't gotten dialysis and had no power for a week. And so myself and a med specialist, we figured out where she was based on, street signs are gone. And so GPS, okay, coordinates. And it was like planes, trains, and automobiles. Like to get there, we got in a pickup truck to go to one spot. Then we got on an airboat And then from the airboat, we had to get in a high water vehicle. And then we get to her house and had to like get upstairs. And the first thing, like I see her and we're going through things. And it's, I mean, this is general medicine. Oh, you missed dialysis. So I'm worried about potassium and ECG. And she actually coded, went into cardiac arrest right in front of us as like, I'm like telling my medic to put electrodes on, get a 12 lead immediately. And so we're resuscitating her. And so you have to bring all your gear and this and that, and you just think about it because you don't even have dispatch calls. It's just like, okay, we're going. And we got Rosk, and then we had to hook up. They had an elevator, as we're on the second floor, and we had to hook up a car battery to the elevator to be able to get her down. And we still had to get her out to the ambulance that was about 4 miles away. And Fish and Wildlife brought an amphibious vehicle. Their amphibious vehicle is made with for 2 seats, and we had 4 people plus a patient lying down, and you know, in the back is just this big motor. So you have to figure out how you're going to put someone on this amphibious thing and still be able to provide care and deal with all of the snakes that were displaced, and man, the floating balls of cities of fire ants that if you touch, like you're getting annihilated. That really sucked. And so treating her and then getting bit by all these fire ants and transferring the patient to EMS, and then, you know, trying to make sure you're not going to anaphylaxis or anaphylactoid from the envenomation. That was just like crazy. And I remember the house, and then immediately it was like, oh, now we get a call about, you know, there might be people in this house that's collapsed. So that always kind of rang amazing. But I mean, Will, you gotta.
Yeah,
Do the one with the CPR on the.
Yeah, cardiac arrest save in the wilderness is probably one of my go-to cases. And again, I think there's so much that we do in wilderness medicine and just medicine in general where kind of we don't get to make a difference. And so I think it's those cases where you actually do get to make an impact. And so had a gentleman who had chest pain about 3 hours skinning up the side of the mountain in the Tetons. Couldn't have any more kind of physical strength to continue on because he was having a myocardial infarction. And as we were short hauling in underneath the helicopter, he went into cardiac arrest. And so his companion started push hard and fast in the center of the chest, kind of the public service announcement message. And so we got there, was able to take an AED. And again, this is some of that kind of thought and pre-planning. So I've got my avalanche gear, I've got my 24-hour pack. So if the helicopter doesn't come back and get us, we're not going to be like the patient or the kind of person that the firefighter had to help get out as well. And so got about kind of, again, this amount of Cuban weight in your backpack. So it's an AED. I took some aspirin and just a couple other kind of basic medical supplies. And we were going to do an extraction, but then we had to move on to plan B because he went into cardiac arrest, put on the AED, shocked him. And within 10 minutes, he was alert and awake and talking to us again. So then continuing that pit crew CPR, kind of the resuscitation, the chain of survival, getting him to the cath lab. And so again, it's just a little bit more steps in that process, but definitely a life saved. And we did a podcast for him if anybody else wants to listen to the story. So our Backcountry Zero, you can Google that. That's the preventative search and rescue arm of our Teton County Search and Rescue. But we give all sorts of these case reports. And I think one of the most interesting take home from a lot of those cases is just what the patient's perspective is, what's the friend's perspective is. Because a lot of times we get so caught up in the rescue and kind of the operational stuff, but understanding and kind of realizing what's going on around us for other individuals is pretty neat.
Yes, I'll share a story that I've done a lot of like rescues that are like objectively dramatic and have gotten a lot of national news coverage and went viral, and hoist rescues and polytrauma patients who've fallen 100 feet off a cliff and we're doing ALS care while we raise them and a rope, all that kind of stuff. But one of the ones that's been significant to me for a long time is a lot simpler and probably like a lot less sexier, but is more significant because I think it really epitomizes actually what wilderness EMS really is all about. So this was a trail runner training for some sort of triathlon or something like that. and he stumbled and dislocated his shoulder beneath one of the arches, sandstone arches here in the Red River Gorge that we're kind of famous for. And so he was about 1.5 miles, from the trailhead, and the terrain was pretty rugged. So the gorge, is a gorge, so there's pretty significant elevation change. And so, it's like he wasn't that remote by any means, but a lot of switchbacks and rock stairs, and just kind of a gnarly trail to get to him. So that also meant that getting him out of there was if we had to carry him, if for whatever reason he was non-ambulatory, was going to take a while. And then even if he was ambulatory, it really sucks to have a dislocated shoulder while you try to hike out of a place like that. And so fortunately, my agency has a shoulder reduction protocol. And so, we knew it was a shoulder dislocation. That was his chief complaint, that he was able to, relate to dispatch and everything. So we kind of knew what we were getting into. Of course, we didn't know if there were other injuries from that fall, or whatever. So we organized the STAR response. We get to him, and he's in a ton of pain. It's like 10 out of 10 pain, and he's shaking and crying and like dry heaving. And so we take some initial steps to get him calm and comfortable. After an assessment, determine that it's reasonable to try to go ahead and reduce this anterior dislocation in the field. So we use Cunningham's technique as our first line, and it wasn't working. And it usually is pretty successful, but there's that percentage where it's not going to work, so it wasn't going to work. So then our second line is like Coker's technique, but that requires a lot more manipulation. And by this time there was a lot more spasming, and he was in even more pain, and pain pretty refractory to our first line analgesics, like fentanyl. And so I talked it through with the patient about I can give you a lot of ketamine and make you pretty happy for a while, and we can try one more time to put the shoulder back into place, or we can just kind of sling and swathe it, and we can manage your pain while we get you out. And he was willing to try that reduction under ketamine. So now we're essentially doing like conscious sedation. I mean, if you look at that at like American Association of Anesthesiologists, like scale of like what's deep sedation or deep analgesia versus conscious sedation, is probably debatable. But the point is, like, I was going to snow this guy with a bunch of ketamine. So that means we're going to do airway monitoring. And so we're talking wilderness EMS here. We're talking like trying to get to kind of the same standard of care that you would expect on an ambulance. So I'm gonna put this guy in the K-hole. So I put him on 2 liters of oxygen. We do carry typically a D cylinder in on a lot of our calls. So put him on 2 liters of oxygen. We put him on end-tidal continuous waveform monitoring. I develop an airway plan and communicate it to my partner. And didn't think I was going to need it, but in case we had that plan, went ahead and located our kind of like plan A airway equipment. Let's go ahead and just pre-position a bag valve mask. Let's make sure we know where our rescue airway is. Let's make sure we know where our surgical crite kit is in case that gets crazy. Let's make sure that we have our little hand-powered suction device, the squid device, handy in case that becomes an issue. And the thing is that the search and rescue team that we embedded with to go in to find this patient, again, they're typically like sort of lay rescuers. They thought that we were like really getting ready to do like full on like damage control surgery on this guy. They see bag valve masks and IV access and all kinds of stuff. And fast forwarding a little bit, like they're like pretty blown away and slightly horrified. So when we did our little debriefing at the trailhead after we transferred him to the ambulance, they were like, "Oh, we've never seen like all this stuff," and that was like real crazy. But the thing is, like, for us, that's just like that's the typical approach to a patient, right? Like that's what you do as a paramedic, and you have your airway plan and you have your contingencies and you practice safe patient care. but we were able to leverage all that sort of stuff, a mile and a half in the woods down this trail system. And so we had the airway equipment, we had the controlled substances, we had appropriate monitoring equipment like a field portable waveform end tidal CO2 device. We had oxygen, we had it all, we built it. We had the whole system basically of care, to apply. That's Wilderness EMS. We were using protocols, standing orders under, medical direction. And we weren't, improvising like a lot of this, right? We were doing it. And so, in the grand scheme of things, I don't think that's like a super exciting kind of call, right? It's like it's a shoulder reduction. I mean, if I used to work as an ER tech, and if you for ER physicians, it's like how many, it's like that's, doing joint reductions under a little bit of sedation is like super routine. So as far as like patient care goes, I don't think it's super high speed. And as far as like the mechanism of injury, it was pretty simple. But I think it just really highlights exactly what we mean when we talk about wilderness EMS and that organized aspect. So that one really stands out to me. And was, proud that we were able to sort of like leverage all that work that we had done to build a real wilderness healthcare, sort of system to be able to do that.
Yeah, that's a really great story. A couple of our panelists, the four of them that are over at conference, sounds like they'll have to deck out soon. So do you guys in that room have any last minute advice or things you want to mention?
I'd just say, I'm one of the ones that has to scoot, but I would just say, do what you're doing. Like, go to things like this, network, always have humility, and just keep reaching. Like, I like doing things on my tippy toes. So like, you're reaching for the stars, but you're still staying grounded. You see what I'm getting at there, right?
Look at you.
But and just find your groove. If you can't find your groove, make one.
I think like Chris mentioned, it's making sure that if you're really wanting to get out into the wilderness austere realm, that you're physically capable, fit, have your own base technical skills, because you don't want to be that extra person that turns into a patient and makes it more complicated. So really need to have that self-proficiency if you're going to be going out into some of these operational environments. But again, there's all sorts of different ways to do that. And so you don't have to go run a marathon or climb the highest mountain. You basically just need to find what your niche is, make sure that you're capable and safe to do that. And then you can bring all your patient care knowledge to that.
Yeah, to be ready for the mission that you're going to do, right? That, I mean, like I can tell you right now that like I'm good to go with certain things, but there's other things that I'm not good to go on, right? And knowing what those things are. And the way you do that is by training, right? Is get out there and train, test your limits, don't stay in your comfort zone, right? So go get yourself outside your comfort zone of your knowledge, outside your comfort zone of your skills, and always be ready to learn something else. And I think a lot of the people here, I think one of the things that I think was common is that I think most of us, and you talk to most of the people, are doing something that didn't really exist until they kind of helped make it happen, right? And that's, I think, one thing that you'll see here. I mean, I'm looking around, that's what everybody here has done. And so there, if you say like, well, what path do you take? It's like, you take the path you want to. You do what you want to do, right? And that's
least resistance.
Yeah, and sometimes that's the path of least resistance, and sometimes it seems to be the path of most resistance. But yeah, that's the thing, is like, just if you can, if you want to do something, just do it, just figure it out and make networks, right? That's the way to get everywhere. I think that's what kind of come to here is that, make and maintain a network of people in your life that will like make not only things easier to do, but also a lot more enjoyable. Like one of the things I love doing is with all my buddies. There's some of my best friends too, that and the things that you're doing in this space as well.
Well, thank you guys very much for joining the panel. Appreciate all of your knowledge and expertise and stories. That's a great segue into our next question. We've got a first-year medical student asking, what advice do we have for getting into wilderness medicine and austere EMS? And I'll just relate some of the things that were already put in the comments. Definitely joining a student interest group is a great way to get involved. Seth has an externship program you can get involved in. The WMS has a couple of electives for both students and residents. And then again, looking in your local area, seeing who has what. And as you start getting towards third and fourth year of medical student, thinking about is that something you want to make your residency choices on, somewhere that has those, you know, residency electives or fellowships potentially at the same program that you may want to go on to.
I
Any
think
other
it's
advice?
important to just add on that as the panel, the group who was in the room, they're in the tower next to me. So I'm in a different tower than they are. It is a matter of sometimes you just stumble into your niche. And I think for a lot of us, that's what you've heard, is that we started out on one pathway. For me, it was in the military, and I stumbled into, you know, remote and austere care that way, but everybody kind of stumbles in their own way. If you already know you have that interest, you know, and I would start small. If you're not sure what part of it you want, go get your woofer, your wilderness first responder, if you haven't done that already, and just kind of say, okay, yeah, this piece I like, this piece I don't like. And then the nice thing about all of these people who've been on this call tonight is it's like it's all over, right? You can do Alaska, Arctic, Antarctic wilderness remote and austere care if you're into that. You can do subtropical rainforest care if you're into that. You can do high altitude. You can do dive. You can do wildland fire. You can do disaster mass casualty. So it's kind of a huge area. So don't think it's a small world. It's getting bigger. It used to be a very small world back in the days of Paul Auerbach's first edition of the book and Eric's class of 99 uses of the safety pin. I mean, I remember going to those meetings and there was a handful of us. It's a big world now, and networking and reaching out. And, you know, I'm more than happy to help answer questions if I can. I'll throw my contact info in the chat. And sometimes we can mentor people in different ways. Volunteer, I echo that. I think that's cool. You know, ski patrol, hiking, climbing clubs, river rafting. I mean, it's all over the map. So it's basically kind of find your interest and you will find a need. You will find a need.
All right, in our last little bit of time here, if we have any other questions from the group, if you want to unmute and ask those questions, feel free to do that now. If you don't want to speak, feel free to put it in the chat and I'll read it for you. And then from our panelists, any other stories, advice that you'd like to give to our group?
I think I'll just close briefly by saying, you know, I guess from my perspective as, you know, being one of the kind of project leaders along with Seth, and then another physician, not on the panel, Jeff Thurman, on the WPC development project, that involved contacting people all around the world to see whether or not this was something that there was even a need for, and, you know, kind of to what extent and what was the scope of the activity around what we had defined as wilderness EMS and wilderness paramedicine. And it turned out that there's a lot of activity going on, and it's kind of exactly, I think, what Dr. Curry was just sort of saying about, like, you know, actually this really is like, this is a real specialty. And I think there is sort of like there's been almost like a watershed kind of thing that's happened over the past just 5, you know, like maybe 5 to 10, maybe it's more like 10 to 15 years or so, where it, you know, I think very similar to the history of emergency medicine itself, this really is developing into a real specialty, a real recognized specialty. You see that, right, with fellowships at medical schools and major academic centers, and the creation of a Forest Service EMS program and a full-time Forest Service medical director, and many different kinds of uh, anecdotes, I guess, or examples like that, where when you sort of zoom out just a little bit, you realize, man, this isn't just like a hobby. This is a professional track, and I think the more people who embrace that sort of ethos of really sort of like the professional practice of wilderness EMS, then that starts to have a little bit of inertia and starts to develop more and more and more into that until it really does become like truly a kind of a robust career track. And of course, depending on your definition of wilderness EMS, that is probably even more true than even I might be suggesting right now. If you think of wilderness EMS as including disaster medicine and humanitarian medicine and military medicine, lots of things like that. That definitely can come with a little bit of risk or sacrifice in of itself, because maybe you feel like you're striking out to sort of plant your flag as like a wilderness EMS physician in a place where nobody seems to know what you're talking about or really what that is. But I think it's worth doing because that's how we really develop this further develop this into something that really is sort of like a sustainable career pathway and sustainable specialty.
Any other last minute questions from the audience?
Seth, I think you probably have the most experience out of making this a profession. Give us some wisdom.
Yeah, I probably just talk about it the most. I think everybody has made this a profession. I mean, but I think that's important to be something we keep in dialogue, because there is no reason why this shouldn't be something we can do. I mean, what you're doing is 100% full-time wilderness EMS, and it's more of a profession in some ways than any of the rest of us on the call have accomplished.
It's 10% wilderness EMS and 90% government BS.
So I wanted to actually emphasize that. Maybe it's a good last minute thing in the chat. I wanted to like wave my hands and jump up and down when you were talking about the fact that what you do day to day may not be hands-on technical rescue. That's such an important message as we talk about building other pathways and building professional roles in this activity. It's not, this is actually the heart and soul of that King and Firefighter essay that I posted in the chat as well about Hurricane Helene. This is what we need in the U.S. Forest Service: is leadership, protocols, accessibility, problem solving, navigating the governmental bureaucracy. So looking for, maybe a message there is looking for the niches that need to be filled and knowing that they're not what everybody thinks wilderness EMS necessarily is a really important consideration. Like Chris said, everybody on this panel probably has started something or initiated something, which almost always is based on a need. It's based on a deficit that could be filled. So yeah, I mean, for crying out loud, in EMS, providing medical oversight for an agency should be the most familiar of activities for a physician. But for some reason we don't, you're walking away from it there in a way that you should be fully embracing it. Like this is exactly the sort of space and roles we need to fill. So just to say what we thought 10 years ago was a role in wilderness EMS may not be recognizable until somebody creates that pathway and builds the role that we need. So, and Michelle, I'd also +1 the people in the thread saying thank you for what you're doing. This is true innovation and really critical. And again, as we look at the California wildfire experience, what you're doing is like absolutely critical. So thank you.
Yeah, I'm not doing anything. Dr. Brett Rosen, who would have been an addition, who didn't even make it to NAMSP, who was the CAL FIRE medical director, that's not the job I would want to have this week. For sure, I would not want to have his job this week. But yeah, no, thank you for the kind words. They're well timed. I had a little bit of aggravation today, so it's always good to get a little bit of encouragement. But yeah, I think that's a really important point, Seth, and I just put it in the chat, is like, don't feel like you have to be a Jack or Jill of all outdoor things. You don't have to be a mountain climber or a deep sea diver or a fantastic skier or rappeller. If you like the outdoors a little bit and you think you want to get involved involved, there's still a place for that. And I'm an example of that. I love the outdoors and I love all that stuff, but I'm not an expert in any of these activities, but I just know a lot of them, and that makes my job a little bit easier. So there is a role for people who don't want to be technically involved or practically involved or hands-on. I don't think there's many of them in this crowd, but if your passion is more policy and admin, there's a role for that in wilderness medical as well. So that's an important point.
Well, thank you again to all of our panelists. We've had decades and decades of experience here in front of us tonight, so that's been a great resource. Thank you all for coming. If you guys have any other follow-up questions, shoot them out to me and we can try and get those answered by some of our panelists for you. As always, the recording will be available afterwards. So for any of you who missed part of it or want to share it with others, that will be available. And look forward to seeing you all at the next Journal Club. Thank you, guys.
Thank you all. Happy New Year. Take care.